The topics we're going to cover today are acute gallbladder problems. We're going to talk about common bile duct stones, a little bit about ERCP, and then bile leaks, which are one of the either presenting in hospital or after I've gone home, cholecystitis. Acute pancreatitis is such a big topic, but if we have time, we'll just cover it at least briefly. So, from the beginning, biliary colic, acute cholecystitis, so it's a spectrum of severity, and the actual label isn't important. But it is important to know that it is uncommon for patients with acute cholecystitis to be very sick. Diabetics and immunocompromised certainly may be, but it is otherwise uncommon. And if a patient comes in with gallstones, label cholecystitis, who is very sick, think cholangitis. Liver function tests are probably the best early discriminator. They're usually only at most mildly deranged in patients with cholecystitis. So an urgent ultrasound, not just for stones, but looking at the gallbladder wall and looking at bile duct diameter. And the liver, every now and again we'll have a patient presents with a liver abscess, and their presentation is very similar to patients with biliary colic or acute cholecystitis. If they have to come into hospital, well, then they warrant antibiotics, no nasogastrics. Don't forget your thromboembolic prophylaxis. Patients can stay on aspirin, but other anticoagulants and antiplatelets should stop. And then a general view is that these patients should be operated on semi-urgently, though the reality is that they often don't get their operation just for logistic reasons. But it is better to operate early on that admission if one can. There are a few patients who come in who are older, frailer, ones with delayed presentation. If they've got a distended gallbladder on ultrasound, then the option is to do a percutaneous cholecystostomy. It's very safe, it is effective. For the frailer patients, it may be a definitive procedure. They may not go on and have a delayed cholecystectomy, but for other patients, they'll have a cholecystectomy at a later stage. So just on to management of common bile duct stones, there's an ERCP cholangiogram showing the very obvious stones. So some are asymptomatic, quite a lot are detected on intraoperative cholangiogram. The symptomatic ones, the pain of stones in the bile duct are exactly the same as stones in the gallbladder. It's a typical biliary colic. And they of course may present with obstruction of the bile duct, either just with jaundice or actually with cholangitis, and then some come in with that gallstone pancreatitis. Ultrasound is the initial modality, of course, and whilst it's very accurate at demonstrating the stones within the gallbladder, its sensitivity for stones in the bile duct is very much lower. And what we're really after is indirect evidence of a stone in the bile duct, which is a dilated bile duct. And as you can see there, the greater the diameter of the bile duct, then the more likely there is that it will harbour a stone. Abdominal CTs, non-contrast CTs are a waste of time. Unfortunately, some patients, particularly after hours, coming into our hospitals, have a non-contrast CT. The CT cholangiogram is a very accurate test for a stone in the bile duct. The contrast is excreted by the liver into the bile duct to produce the cholangiogram. That therefore requires adequate liver function, and if the patient is jaundiced over and above probably a bilirubin of twice normal, that CT cholangiogram will not work. The problem with CT cholangiogram, apart from not being able to do it on jaundiced patients, is the risk of contrast allergy, and it's probably higher for this procedure than I think any other radiological procedure. So we like MRCPs because they produce as nice pictures as the CT cholangiograms, but it doesn't have, you can do it on a jaundiced patient, and the only contraindications are the usual contraindications for an MRI, which are usually some metal in the body, pacemaker. And that's the sort of picture you see with a MRCP, just beautiful pictures, stones, you can see the little fine pancreatic duct. The VSCC is published on this question of what one does with stones in the bile duct diagnosed preoperatively. And basically, the decision needs to be made preoperatively what you want to do. And the options are, you can either remove the stones beforehand at ERCP, or the patient can have a laparoscopic exploration. So either is acceptable, but what is not acceptable is deciding to do a lap chole and just leave the stones till post-operatively. If the stones are diagnosed for the first time intraoperatively, then the options really depend very much on the experience of the operator and the equipment available as to whether they're going to go down the path of a transcystic exploration or a laparoscopic bile duct exploration, or they're going to refer a patient post-operatively. So these are the guidelines, and if I'd encourage anybody to have a look at the VSCC site to see these guidelines. So they start off by saying that the stones diagnosed preoperatively should be managed either at operation or with preoperative ERCP. Jaundice patients should have a diagnosis made before surgery. Patients with jaundice who've got stones in the gallbladder, it isn't necessarily so that they'll have a stone in the bile duct causing the jaundice. They may have a malignancy. MRCP is very useful. Operative cholangiographies, I'm not going to enter a debate as to whether they should be used routinely or not, but if they're going to be used selectively, at least they should be used, have fairly broad indications. And unsuspected bile duct stones picked up at operation we've alluded to. So just a little bit about ERCP, preoperative preparation. Coagulation obviously needs to be corrected. Well, it should be corrected ideally. But if the patients are sick, we may go ahead, despite the fact that they're still on clopidogrel or still on warfarin, and we may settle for putting a stent in without cutting and therefore without a risk of bleeding. IV antibiotics, a lot of debate about what the most appropriate antibiotics are at the moment. The risks that you need to be able to tell the patients about, overall the risk of pancreatitis is probably about 5%. That's historic. It may well be that it's less now. Bleeding from a sphincterotomy about 1 in 100, perforation about 1 in 1,000. Failure rate though about 5%. We can only do the procedure in probably 95% of patients. There are anatomical reasons that we can't do it in a few. Cholangitis is a rare complication of ERCP, and usually only if the patient has an undrained bile duct at the end of the procedure and has not been given antibiotics. And these are sort of a list of anatomical difficulties we might encounter, and they're also mechanical ones, from esophageal obstructions to previous gastric surgery to duodenal strictures. And basically we put a cannula into the bile duct, try to avoid the pancreatic duct. We obtain a cholangiogram. We use a sphincterotome, that little wire is that wire is our cutting wire. We always have a guide wire in place. So we go up to the bile duct and then we start cutting with this cutting wire to open up the distal bile duct. Pass a balloon up into the bile duct and pop out the stone. Yeah, that is beautiful. And then sometimes we'll put stents in. We have this whole variety of plastic and metal stents, but basically we put stents in if bile ducts are left, there's still a stricture or there's still stones left. And all sorts of stents, including this type of straight stent that we'll leave in for a while. Now, bile leaks may occur and be evident in the immediate post-operative period whilst the patient's still in hospital, or the patient may come back to hospital over the next few days or week. And the clue is that the pain is out of proportion to what you expect for a laparoscopic cholecystectomy. And this applies to all laparoscopic procedures. If the patient has pain that is greater than one would expect for a laparoscopic procedure, you have to assume it as a complication until you've excluded it. And that complication may be bleeding or bile leak, or it might be, as Barry has mentioned, a visceral injury. And presumably all those patients who went to the coroner, Barry, who died from their visceral injury and the bladder injury, they must have had the diagnosis missed, because you don't die because you've had an instrument put in the bowel or put in the bladder. So they've all had their diagnosis missed. And so pain, the usual abdominal signs and fever, etc. A warning about drain tubes. Obviously if there's bile coming out of drain tube, well then they've got a bile leak. If they haven't got bile coming out of drain tube, it does not mean they don't have a bile leak. Equally, if they don't have blood coming out of drain tube, it doesn't mean they're not bleeding. Drain tubes do not always work. CT, triple phase CT is important. If they haven't had an operative cholangiogram and you're suspicious of a major injury, then they probably should have an MRCP. And the priority of the treatment of a bile leak is not to stop the bile leak, it is to get rid of the bile that's in the peritoneal cavity if that needs to be done. So you have to ask yourself, does the patient have to go to theatre and have their peritoneum washed out, usually laparoscopically? Is it a smaller collection that might be suitable for radiological drainage? And then there are a group of patients, if they're not particularly sick and it's only a small amount of fluid in the peritoneal cavity, then that you could sit tight with antibiotics, particularly if there's a drain in place. ERCP is for those patients who've got large volume leaks or smaller volume but are persisting, and then we do a sphincterotomy, get a cholangiogram, find the site of the leak, pull out a stone if they've got a stone there, because an obstructing stone will aggravate the problem, and usually put a stent in. And this just shows the cholangiogram. There are the clips on the cystic duct stump, and they're showing an obvious leak from the cystic duct stump. And this is the cholangiogram, and this leak is from a little duct in the gallbladder beds, sometimes called a ducta brusca. VCT is also written on the management of cholangitis, because we have often failed in our management of cholangitis. Most are due to gallstones. Malignancy rarely presents with cholangitis unless they've already been instrumented and have a stent in. And it has potentially a very high mortality. And the principles of management are obvious: resuscitation and IV antibiotics, urgent imaging, so an ultrasound to start with. If that may give you enough information to proceed with ERCP, they may need to go and have an MRCP. Don't forget blood cultures and coags. And then it's important to assess how urgent does biliary decompression need to take place. And these are the VSE guidelines for the management of acute cholangitis. So the most appropriate method of biliary decompression is ERCP and sphincterotomy and stenting, and nowadays with surgery. For many years now it's been ERCP. A small group of patients presenting with cholangitis, 10 to 15%, will not respond well to initial resuscitation and need an urgent biliary decompression, i.e. within hours. There's another group who have responded, but they've got poor, they're elderly, they're frail, and we would still want to do them early. Most patients, though, do respond to initial measures with antibiotics and fluids, and they can be done any time within the next 2 or 3 days. And all hospitals need to have access to ERCP facilities on an urgent basis. Not in-house, but you need to have some pathway to obtain an urgent ERCP. And indeed you should consider transferring such patients early, particularly if you don't have appropriate ICU facilities. Now, we'll just talk very briefly about acute pancreatitis. So, two of those three features of abdominal pain, hyperamylasemia or raised lipase, or imaging characteristics of acute pancreatitis make the diagnosis. there are a lot of classifications of pancreatitis. This is a basic classification that breaks it down into those patients who on the basis of imaging have necrosis, so the sicker ones, necrotizing pancreatitis, and those that do not. And then it's classified into severity as mild, moderate and severe, and local complications, which is all in your handouts. And so at the beginning, when they first present, you want to try to determine the severity of the pancreatitis. And that's done on the basis of their story, their clinical findings, some radiology and the lab investigations. And there are all sorts of scoring systems, but it's important, rather than to give them a score, to know which parameters are important in determining their severity. CT scanning we don't usually do early on, but if they're sick, we will do a CT or an MRI at about 72-hour mark to really see whether they've got pancreatic necrosis or not, and to try to predict how they may fare. And this is just a typical picture of a patient with severe pancreatitis, contrast in hands, non-contrast CT in acute pancreatitis is sometimes done because their renal function isn't so good, is in essence a waste of time. And this shows the fluid collecting, this very inflamed pancreas, not very good perfusion in the head, fluid already collecting. They need to be, all patients who are sick with pancreatitis need to be referred to ICU early. ICU may not accept them at that stage, but they need to be aware of them, because the patients will often deteriorate after 24 hours. So usual supportive care, fluids, pain control, nutritional support just comes a little bit later. Aggressive rehydration, particularly within the first 24 hours, is shown to reduce mortality, but you have to be very careful after the 24-hour mark, because that's when they're going to start running into trouble with fluid overload. Pain control is absolutely essential for both their circulation and to try to prevent respiratory complications. Opiate PCA is standard. And then the question of what stage should they be referred to ERCP. Certainly if they've got cholangitis, well then they're treated as a cholangitic. If you think they've got a bile duct stone still present, and that's evidenced by abnormal LFTs that aren't improving, some ultrasound evidence, then you'd like to get the ERCP done within 48 hours if you're going to do it. Now, there's a lot more to pancreatitis which we can cover in panel discussion if people wish. Thank you, Peter.